The last one before our next coffee break is Heyrim Cho from ASU, and she's going to be talking on some Bayesian information-theoretic approaches for screening.
So yeah, thank you for the introduction and opportunity to talk about my so yeah, the title is long, but basically here the goal is to try to think about patient-specific data collection schedules, being more adaptive in data collection in the clinical patients. So I work in mathematical oncology, and here, like in these days, working in math oncology, we can't escape from data, right? We need this data to inspire our models and calibrate to our models, and etc. But while working in this field, I always wish there are more time points because I develop models with temporal dynamics and our goal is to make predictions, right? So I wish there were more time points, always I feel that way, but it is understandable why we don't have a lot of time data, especially in clinical data. Because if you think of what data we can collect from cancer patients, they're either expensive or invasive. You can think of many of the imaging modalities, which are expensive. You cannot ask for like 10 or in a big magnitude, right? Also, there's cool spatial temporal omics data these days, also expensive. And on top of that, some data collections are invasive to patients, right? You say it's simply blood draw, but it's blood draw, right? And tissue biopsy and other fluid biopsy, etc., are also invasive, which could be a burden to patients who are already going through a difficult time because of their underlying disease. So this this clinical data being either physical or financial burden to patient could be a limitation that gives these clinical data having temporal aspects of this clinical data being limited. And this is an example that I often give. And in radiotherapy patients, you usually get 1 or 2 MRI scan prior to the radiotherapy. And then you go through the 6 to 8 weeks of radiotherapy. And then you get another scan at the end of the treatment to see whether you did well or not. I know in these clinical trials tied with mathematical models, you often get 1 scan per week. There is an MRI linac that you get MRI every time you get the radiotherapy, so daily. However, still, if you think that the average patient's number of scans, it won't be in the like tenfold in the near future. So my collaborators and I thought about then, okay, we know that there's not a lot of budget, then at least can you think about whether we can optimize the time point, optimize when we should take these MRI. And so for that, our framework, again, is to develop this way of deciding when to scan the patient in some optimal manner. The framework is general. If you have data and then corresponding identifiable model, it works. But to establish the first result, we set up a simplest setting where the collectible data is just a tumor volume. So each time point, you're going to have 1 number. And then because I have 1 number, I will calibrate that into 1 ODE model, which is simply logistic growth with the linear quadratic radiotherapy term. And so radiotherapy, we're going to assume 6 weeks and Monday to Friday scan. And then here is an example of the data that we generated, not patient data. It's still synthetic data we generated with the hybrid agent-based model. But the thing is, we'll have to do this in a sequential manner, right? So here, the black and dots are the one that we use to calibrate the model. And then the right is the model parameters. And then as we include more data points, you can see the prediction getting more accurate and then also the parameter value becoming more saturated, like value becoming converging. However, here I'm giving just equidistance data points. Can we move around these data points to get a better and accurate prediction earlier? So the methodology that we'll use is a Bayesian information based on Bayesian information theory. So we'll be trying to estimate the posterior distribution of the parameter theta given the data set. And the dn is the data set that includes n time point data, and it's a sequential matter. So I here divided into dn minus 1, which is a previously collected n minus 1. And then how can you collect the new data point, lowercase dn. And the quantity that we use in selecting this dn is called mutual information. And it has this long expression, but it's nothing but we're trying to reduce the uncertainty in the model parameter. So for example, in the radiotherapy model, we want to reduce the uncertainty in the radiosensitivity parameter as much as possible by selecting the new data. It's called information theory because the uncertainty reduction is called information gain. So if you look at this term, it's the uncertainty or the information at the dn minus n, and then minus the uncertainty by adding the next data point dn. So it's really maximizing the reduction of uncertainty or maximizing the increase in the information about the radiotherapy response. So this is going to be the algorithm where we have n minus 1 data points. So at this point, we're gonna, we already fitted the model, and then among the remaining data points, we're gonna compute the mutual information, and then select the next data point that has the maximal mutual information value. So this is selected, and then we go around, again, calibrate, and then among the available data points, and then continue, all right? So some simulation that we did. So at the beginning, we wanted to be more modest. Here, our goal is to select the best day. So our budget is 1 scan per week, and we want to select the best day to scan for each week during the 6th week of radiotherapy. And we generated highly responding patients and then less responding patients, see which day we select using this mutual information quantity. And those are the week 2, 3, 4, 5, 6. They selected. This was not informative, but here you can see for highly responding patient, you realize that you keep selecting the Monday scans toward the end, while in the less responding patient, you select Monday and then Tuesday and then Saturdays. Now, what's happening? This is actually a bit misleading. If you look at the mutual information, the quantity that we use to select the day, for highly responding patient, Monday is always the winner. However, for less responding patient, at the 2nd week, you select Monday, but then the quantity is the mutual information almost similar among Monday to Sunday, meaning that any scan among the week is going to be similarly informative to learning the radiotherapy, the sensitivity parameter. And it makes sense because here I'm trying to learn how the radiotherapy, the patient is going to respond to radiotherapy. And if you look at the radiotherapy schedule, you actually have the weekend break. So Saturday and Sunday, you don't get radiotherapy. And then Monday is actually the day that you actually learn the dip because of the radiotherapy. And for a patient that has more dynamics because of the radiotherapy, you want to take the Monday scan so that you learn the dip. However, for less responding patient, first you select Monday and you learn the dip, realize that it's actually not much dynamics happening, then it's saying that, okay, any day scan will be similarly informative to learning just that non-stiff, that dynamics. So we thought that it makes sense and thought about, okay, let's open it to the whole 6 weeks and see what happens. And we ran into trouble because these sequential experimental design, experimental design optimization has no problem if you consider spatial data because, for example, think of selecting the sensors. You choose n-1 sensor, and then among the remaining one, you can choose the next nth best sensor location. However, if you think of temporal data, that's not the case. Once you select a day, your previous days are gone, right? So if you select that, okay, I'm going to scan day 5, select that. It means that your 1 to 4 days are gone. By a little bit of chance, if you select the end of the treatment, then it means that you're already at the end of the treatment, right? So we realize that we need to somehow compensate for this time pass, penalize scanning at the later time because our goal is to predict early, right? That's one of the goals. So we suggest this object function, which is correction to the mutual information. Here it's R, that's exactly the mutual information, just rescaled, normalized. And this is a term that we add into the object function, which is the temporal penalty term for the temporal information loss, which is nothing but the percentage of the information, where the bottom is the information summation from day to the end, and the top is the information summation from current day to the selection of day. So it's really the percentage of how much information that I lose. And then here, there is a penalty coefficient. We wanted to get rid of that. So by a lot of trial and error, that was what we selected. And here are some results. So for the radiotherapy, you can see this is our chosen 6 scans for more responding patients, which are around here. And then, I mean, if I was very thorough and was less lazier, I would have compared this with all the 6 combination, but I wasn't. And here we compare with the weekly scan. So it's 6 weeks treatment. So we selected, okay, every Friday scan will be the equidistant scan, and then the first 6 scan. And here, the first 6 scan is doing not good, right? As you expected, but we wanted to as much as the weekly scans, and we actually do in terms of error, which is just the mean square error of all the data, and then the model, and then the uncertainty, which is the 95% the area of the 90% critical interval. You can do it. We realize they do it similar. In the strong responding patient, we actually end early, so we're getting similar prediction results in the mid of the treatment, and also for less responding patient, we do it with less number of points. Here it's 5 points, which is less than 6, but you see the end, there's a lot of cluster, which you can probably clear out with some post criterion. Here is another result where here I have more ODs. So we also wanted to test for clinical data. Here is the prostate cancer going to intermittent androgen suppression therapy. And here the data is the PSA level and then the androgen level. So and the corresponding model is taken from other work where it's 5 ODs and the androgen is going to be gone into here. The PSA is going to go into over here. And we will try to learn these 4 selected parameters that we realize that are most sensitive to the treatment response. And here as well, we want to select the date for 1.5 cycles and then predict for 3.5 cycles. And here are the results, similarly comparing first 5 scans, evenly spaced 5 scans, and our chosen scans, which surprisingly, it did better than the evenly spaced scan, which is by chance because the evenly chosen scan didn't pick the peak, right? So here you realize that if you pick the peak and then the bottom, that will kind of give you the accuracy. However, by luckily, we did not just by similar, but did better than the equid-spaced scans, and then our certainty was also in a reasonable range. And this is just doing PSA, but here we also included PSA in both androgen, and then now we select 10 chosen scans, and here we're doing much better, especially here we actually take the peak. We were able to resolve the peak, get the peak point, and then the accuracy was better. So yeah, I think I'm showing, because of the time, I'm showing this the best result, but there's a lot of things that limitation and bottlenecks I sit through, which I'll be happy to talk about if you're interested in. Now, this is the last line of work. I think I'm going over time. I'm almost done. So you realize saw my selected scans, this initial growth phase, it just doesn't make sense. So currently we're doing nonlinear mixed effects modeling to model the prior distribution of the population, and then also like refine that into a group so that we get rid of the initial, and then we just start from the day of diagnosis or the day of treatment. And then we also have the criterions to just clear out the S by looking at the convergence of the data points. And then this is kind of more recent result where you can see this was our previous result, and with the equidistant scan, this is our most recent result where we just start with a single data point at the time of like treatment, and then we do a couple of data points, and we're getting similar or better accuracy than the equidistant one. So that's this is unpublished. So now that I presented, hopefully I can get that out. So so that was the work that I want to talk about. This is the summary. So patient-specific adaptive data collection, so that we can do better in terms of optimizing to make our mathematical models more useful. So that was the work. These 2 are the reference, but I think there's a lot more to do. And yeah, thank you for your attention. Thank you for, this is my main collaborators on this work. I always thank Russ and the people at City Hall for inspiring me, and my students as well. And thank you for attention.
Thank you, Heyrim. Are there any questions? Yes, sir. Pardon me. There you go.
Lovely talk. Thank you for that. Just a question with that. We know within the cell cycles that there's actually different radiosensitivity with the different treatments in itself. It was just a question with the actual scheduling of the different scans and the treatment. Have you thought of actually trying to align that to potentially different harmonics of the cell cycles for the cancer types that you're actually testing on?
Oh yeah, that's a great question. Great, interesting, great question. So about incorporating the cell cycle, and I think we can do that if we incorporate the cell cycle into the model, and especially like chemotherapy or those like radiotherapy, even will be what is it related to that? So I think that could be a future direction of also including the cell cycle into the model, and then also trying to learn that parameter as well, and then and then based on that, I haven't thought about that yet. Thanks for the idea.
How often do you collect data on the cell cycle to include that in your model for calibration?
Oh, in the
No, just to respond, if you now want to add a cell cycle in your model, it's going to be quite difficult collecting some of those to help with calibration, wouldn't it?
yeah, that's true. Cell cycle. Yeah. Yeah, it's like a day or two. Yeah, it has to be more on the biopsy and then fluorescent or something to get those characteristics, or like having a single cell seq type of thing prior to the treatment. So having those kind of information so that we can group them into that. Yes, I think that would be, grouping them and then having that group, it makes more sense. Yeah, thank you.
Thank you for your talk.
Yeah, thank you.
I have just one small question. Would it help if you actually include some type of imputation for those dates in which you don't have access to a scan for your model?
Oh, I see. That's an interesting point. So
For the sensor data, yeah.
I haven't thought about it. So imputation, so excluding.
Actually, finding those points that are
Or missing.
Yeah,
Oh,
yeah.
I see. Yeah, I haven't thought about it, but thank you for the comment. I'll definitely think direction. Oh, yes.
Thank you. That was super interesting. This kind of applies to both, but I think especially with the prostate one, what I was wondering is how important is it to get the model right here? So if you start reducing the number of points when you're collecting data, etc., what if your model is wrong for this patient? Do you have a sense of like what you can still do with the data you've now collected in this way?
That's a very great question. And then that's why at the beginning for some data set, we do select the model by using the AIC or BIC. And then actually for the next data set, I'm actually using Zahid's the radiotherapy paper. We realized that the current radiotherapy model is not good. So at the beginning, we select the best model. But if that model is wrong, incorrectly selected, then that's bad. Right? So I think that you raised an important point that it is important to select the right model, and then that will work well for, let's say, per cancer or per group and etc. So thank you.
All right, so I would like to thank the speaker again and all speakers in this afternoon session, and we are off for coffee break.